Welcome to tonight's teleconference from the International Myeloma Foundation on Chemo Brain. I will now turn the call over to Ms. Robin Toohey.
Welcome, everyone. Thank you, Terry. Good evening, and I'm Robin Toohey, Senior Director, Support Groups of the International Myeloma Foundation. And it's my pleasure to welcome you to tonight's teleconference in support of Myeloma Awareness Month on Chemo Brain. Is it real? What myeloma patients need to know. I'd like to thank our sponsors for their support for tonight's call, Celgene Pharmaceuticals, and Millennium, the Takeda Oncology Company. If you have not yet downloaded the slides for tonight's teleconference, please go to myeloma.org, that's myeloma.org, and click the top bullet under New and Noteworthy, and you'll be able to access the slides there. As our speaker goes through her presentation tonight, please just advance the slides as necessary. These slides are also downloadable and printable for your use and note-taking. Tonight's teleconference is part of the IMF's Living Well with Myeloma teleconference series, which is designed to cover all the important and most up-to-date information regarding myeloma to help you live well. You will have the opportunity at the end of this presentation to ask questions. It's now my pleasure to turn the call over to our special guest speaker, Pamela Joyce Shapiro, Assistant Professor, Cognitive Psychologist at Temple University. Pamela?
Hi, Robin. Thank you for having me. I'm very excited to be talking to this group of myeloma survivors. One of my favorite things to do is to share information with survivors, so this is really a very special night for me as well. So thank you for having me. Okay. I want to say hello to everyone and thank you for being on the call. I hope that I'm able to present information to you that is helpful for you in understanding any cognitive problems that you might have, and also in just maintaining your overall cognitive health, doing whatever is necessary to be the best you that you can be during your time living with multiple myeloma. So what I'm going to do is go now to slide 1. And give me a moment, okay? If you look at slide 1, you'll see that I have a little poem there by Lillian Moore, and I think that this really captures the feeling of Chemo Brain quite well. I left my head somewhere today, put it down for just a minute, under the table on a chair. Wish I were able to say where. Everything I need is in it. Cognitive complaints or complaints about poor memory, foggy thinking, getting confused, not being able to find the right word when you need it, or even getting lost in a familiar place are very common among cancer patients. In fact, if you Google the term Chemo Brain, you'll get well over 1 million hits. That has increased substantially since the last time that I looked, and it's really increased since 12 years ago when I first entered this field. At that point, Chemo Brain was not a term that was commonly known by cancer patients. Okay, so if we move on to slide 2, I'm going to tell you a little bit about how the talk is going to go tonight. What I'd like to do is discuss some of the factors that we know impact cognitive function. Then I'm going to briefly discuss some of the research on cognitive function in patients with cancer and with multiple myeloma patients in particular. That way you can get an idea of what we actually know and what we still don't know about cognitive loss related to cancer and cancer treatment. Then I'm going to give you a completely non-scientific primer on how the brain works, and that's going to lay the foundation for understanding how some relatively easy lifestyle changes can help you improve and maintain your cognitive health. So moving on to slide 4 now. Whenever you examine a complex human process like cognition, there are multiple factors that contribute to impairment. And it's very important to understand this because although we can refer to cancer-related cognitive deficits as chemo brain or maybe as chemo fog, in fact, about 30% of newly diagnosed patients have measurable deficits before they start treatment. So in those cases, clearly it's not chemotherapy that's causing the problem. You can't have chemo brain before you've had chemo. So let's take a look at some of the factors that are involved. Going on to slide 5, these list the major factors. They are aging, distress, fatigue, illness, and medication, medication including your cancer treatment. And we're going to look at these one by one. So going on to slide 6, let's start with aging. We know that there are normal age-related declines in memory and processing speed. Many cancer patients are older, and we should expect some cognitive changes that are consistent with age. We also see some minor volume loss in the brain and some neuronal shrinkage beginning as early as the 40s, but that increases after age 50 and then continues. What we know is that there is cognitive slowing, but not a decline in ability. So what you see is reduced reaction time. It may take longer for you to perform a task. It may take longer for you to recall information from memory or to do a mental calculation. But your overall knowledge and your reasoning skill is not reduced. You are the same you have always been, just a little bit slower. So what's typical? We need more time to recall names and words. Multitasking becomes more difficult. And in fact, what you need to know about multitasking is that it's never a good idea. We actually can't do two things at once. Every time you switch, you're actually changing the focus of your attention and you're losing time and efficiency. So it's an illusion that we can multitask. And then what also happens is that as you age, you pay less attention to detail. And if you pay less attention to detail, you remember less detail. Okay, so let's move on to distress. We're on slide 7 now. Many studies demonstrate that distress and depression have adverse effects on cognitive function. Studies show that depressed and anxious individuals are about 40% more likely to develop mild cognitive impairment than non-distressed people of the same age. Symptoms of distress and depression interfere with attention. In fact, an inability to concentrate is one of the key symptoms of depression. Both short and long-term stress interfere with your attention, memory, how fast you can process information, and spatial learning. What does this mean for you? Well, between 27 to 40% of patients who are being treated for multiple myeloma have significant anxiety or depression, or both. So if you're experiencing symptoms of distress, you very may well expect to have some cognitive difficulties associated with that distress. Okay, we know, moving on to slide 8, we know that brief periods of stress impair cognition briefly, but prolonged periods of chronic stress actually reduce the volume of the hippocampus, the area of your brain critical for memory. So if you look at the slide, you can see in the picture of the brain, there is a sort of long, narrow purple area towards the bottom of the brain. It's just before this little green bean, and that is your hippocampus. And the hippocampus is the area of your brain responsible for long-term memory. Prolonged stress also reduces the levels of neurochemicals that are involved in learning and memory. So the bottom line is that ongoing or chronic stress actually interferes with your brain's ability to grow new cells and to learn. So moving on to slide 9, everyone who's listening tonight knows that cancer is stressful, and it's not a minor stressor, and it's not a transient stressor. The time from initial diagnosis through treatment planning, treatment itself, and ongoing monitoring is years. So I ask you to consider that any cognitive difficulties you experience might be, at least in part, related to stress. And for you, that's actually very good news, because stress is something that you can learn to manage. Whereas chemotherapy, it's out of your control. You have to take your treatment to get well. Okay, so ending up our talk on distress, it seems like across all cancers, younger survivors are more likely to experience depression and be anxious than older survivors. In turn, they also report having more cognitive problems. Most likely that's because the demands on younger patients are greater. They're juggling school, career, child rearing, and illness, and it's very unexpected for them at this particular stage of life to be experiencing illness. So it is more stressful for them than it is for older adults. And that's not to diminish what happens with older adults, but it's a common finding across all cancers that younger patients are more distressed. Okay, so let's talk a little bit about the effects that fatigue has on cognition. We're on slide 11 now. Fatigue is often a symptom of anemia. 50% of cancer patients have anemia, and in multiple myeloma, more than 73% of patients have anemia. Anemia is very heavily associated with cognitive declines. Declines in hemoglobin coincide with declines in cognitive function. Anemia is a risk factor for cognitive impairment in older adults, specifically for executive function, which is sort of command central for directing and coordinating all of your cognitive abilities. So you can see that it has a profound effect. So given the high rate of anemia in multiple myeloma, you can understand how this might contribute to some cognitive loss. Fatigue might also result from disruptions in sleep. And when you lose sleep, it has a profound effect on your daytime attention and concentration, and it disrupts memory consolidation. There's this very interesting study, and rats were scanned while they were learning a maze, and then again while they were sleeping that same night. During sleep, their brains showed the same exact pattern of activity as it did during the maze learning trials. So what was happening while the rats slept was that they were unconsciously cementing what they had learned into their brains while they were sleeping. This is what happens for humans as well. While you sleep, you consolidate the information that you learned from the day before and your experiences. So if sleep is disrupted, you're going to have difficulties with memory. Okay, so let's go to illness now. We're on slide 13. How does illness impact cognition? Cancer itself may alter the neurochemicals and hormones that affect cognitive function. We know that inflammatory processes contribute to cognitive decline, and we also know that cancer is associated with release of inflammatory cytokines, including TNF-alpha, IL-6, and IL-8. These are the same cytokines that contribute to the development of disruptions in cognitive function, and cytokines also contribute to the development of anemia. So they may, in fact, affect cognition through multiple pathways. We don't know the exact mechanisms, but there are a few ways for them to affect your cognitive processes. Aside from cancer, there are several other conditions that can also affect cognitive function. Things like hypertension, cardiovascular disease, multiple sclerosis, and diabetes all have negative effects on your cognitive function. So what's important for you is to be careful that you don't neglect your overall health while dealing with cancer. I know that sometimes cancer becomes the focus, but it's important to maintain your overall wellness. Okay, so what about treatment? We're on slide 15 now, and this slide actually lists some of the classes of drugs that are used in multiple myeloma. Turns out that treatment can have either direct or indirect neurocognitive effects. So direct would be chemotherapy crossing the blood-brain barrier and causing damage to the cells in your central nervous system. Indirect might be side effects of treatment, like anemia, changes in immune function, or damage to the heart or lungs that in turn affect cognitive function. Also, it could be through symptoms of fatigue and distress that often come along with chemotherapy. For women, if treatment causes a woman to go into premature menopause, the loss of estrogen might contribute to cognitive difficulties. And in animal models, the drug prednisone can impair cell growth in the hippocampus. Remember, that's the area that's responsible for your long-term memory. In contrast, when you look at these other cytotoxic agents and you compare it to a newer drug, Velcade, which has a different mechanism, it looks like Velcade actually has some neuroprotective effects. They've done studies with rats, and they give Velcade right after they induce a stroke, and it actually protects and attenuates some of the damage. So that's just an interesting thing to know going forward. Okay, so you can see that many things besides chemotherapy contribute to what I'd like to call cancer-related cognitive loss, because Chemo Brain might not be the right name. But what I think that most patients really want to know is, does chemo give me Chemo Brain? So what we're going to do now is take a look at some of the research. Okay, so when we look at animal studies, we find that there's converging evidence that certain drugs, in particular platinum-based drugs, contribute to long-term neurotoxicity. These drugs actually modulate the blood-brain barrier. They penetrate. They cause neuronal degeneration of the cells in your brain, and they cause myelin thinning. Myelin is the white fatty substance that insulates parts of the neurons and increases the speed of signals in your brain. And you understand that the speed is very, very important, just like in electrical wiring, insulation helps conduct the signal. So if that's damaged in some way, you're going to have some cognitive loss. When we look at methotrexate, animal studies of cognitive function with methotrexate show that it impairs spatial learning and memory, the rat's ability to find their way in a maze, to swim to a platform. It impairs working memory, and it impairs tasks that are associated with the hippocampus and the frontal lobes. So executive function, although I don't think we would describe rats as having executive function, however, it impairs tasks associated with their frontal lobes. So let's now go to slide 18 and look at a study of lenalidomide. Okay? There are actually only a handful of studies that look at cognitive function in people who have myeloma. I'm going to review a few of them here. This is a very interesting case study that looked at two patients. One was 41 years old and one was 70 years old. Both of these patients had acute negative effects of lenalidomide on cognitive function. It was rapid onset and it was severe, and it affected episodic memory. That's actually your memory for events and experiences, and their ability to just manage everyday activities. The symptoms, however, reversed after the drug was discontinued, so it was not permanent. They returned to normal. When they tried to evaluate what the risk factors were, and they looked at the patient's histories, the risk factors appeared to be having had prior chemotherapy to this treatment, previous mild cognitive impairment, cerebrovascular lesions in one of the patients, and, of course, age in the 70-year-old. And you'll see when we look at some other studies that age seems to be a risk factor for greater cognitive impairment in cancer patients. Okay, so here's another study on slide 19, and this is by Stewart and his colleagues, and he conducted this two-arm randomized clinical trial and had a 4-year follow-up after treatment with melphalan with autologous stem cell transplant. You'll forgive me if I'm not saying melphalan right. I'm not sure of the pronunciation. A sample of 332 patients with multiple myeloma received either the thalidomide prednisone maintenance therapy, or they were just under observation, so not receiving additional maintenance drugs. In this study, the cognitive function was not measured by standardized neurocognitive tests, which is really the gold standard. Instead, it was a self-report measured by only a few questions about cognitive function. okay? It was a secondary endpoint, which means that the result is not quite as strong as it would be if it was the primary goal of the study. However, the results showed that self-reported cognitive function was worse in the maintenance arm. And if you look at the table and you look at the difference between maintenance and observation and improved and worsened cognitive function, what you can see is that there was improvement as well as decline in both groups, okay? It was worse in the maintenance arm, but there was some improvement in both groups. And this is, in fact, one of the difficulties we have in this whole area of research, that the results we have so far, because it's a relatively young area of investigation, are very, very mixed. Okay, so let's go to slide 20. This is another recent study, and they looked at 102 blood cancer patients, some of them were myeloma patients, before and after allogenic stem cell transplant. 47% had cognitive impairment before transplant, we'll call that time 1, and 41% had impairment 12 months after transplant, that's time 2. Of all of these patients, only 16% had clinically significant decline between time 1 and time 2. Okay, so there's not a lot of decline following treatment, and it looks like a large proportion of the patients had impairment before they started transplant. Now, this is very interesting. Self-reports of cognitive impairment, not the objective testing, but self-reports, were correlated with changes in brain structure and function in an imaging study. So it actually looks like the patients might notice cognitive loss before it even shows up on a standard test. And that's kind of an interesting phenomenon because patients have been talking about Chemo Brain for a very long time, and they may have gone through testing and found, well, nothing's showing. I urge everyone to follow up and go back because you may be tapping into something. You may know exactly what's happening to you, but it's just not showing up on tests yet. So bottom line for this, a subset of patients do experience clinically significant cognitive impairment following treatment, but we don't know why exactly. Okay, so let's look at slide 21. These are 3 studies that looked at patients with central nervous system lymphomas, and they were receiving methotrexate. So it's included here because of the drug. Not myeloma patients, but the drug is relevant. When you look at these 3 studies, you can see that the results are mixed. In the first study, they did not measure pretreatment cognitive function. You can see it says no pretreatment assessment. It's very hard then to interpret these results because you can't say that impairment is a consequence of treatment. We don't know where they were before, and as you have seen in the previous slides, a percentage of patients has impairment before they start treatment. And in the next 2 studies that are on this slide, there was either no significant decline after chemotherapy treatment or there was an improvement after treatment. And we have seen that in many other cancers as well. As I said, the results are mixed. Some patients will have decline, some will not have a change at all, and others will actually improve after treatment. Okay, so I want to talk a little bit about this imaging study from breast cancer. We're on slide 22 now. And it's interesting because it supports the results of a study we talked about earlier. Olive and Ferguson conducted this interesting MRI study of identical twins who were discordant for breast cancer. They found very minimal differences in objective cognitive testing. That's when you're using standardized neurocognitive tests. But they did find substantial differences in perceived cognitive function, the self-reports of cognitive function. And those corresponded to structural and functional differences in the brain images. What that means is that there were measurable neural changes underlying the breast cancer patient's cognitive complaints. Even though her standardized tests were normal, there were changes in the brain that correlated with her complaints. So this is similar to the study of Sherworth that we talked about on slide 20, in that there were brain changes in cancer patients who had undergone chemotherapy. Other studies that compared patients with chemotherapy to chemo-naive patients, patients with the same cancer but who did not undergo chemotherapy, and to healthy controls, so there were 3 groups, showed that there was reduced brain volume and slower, more diffuse processing in the cancer survivors who had had chemo compared to those who were chemo-naive or to healthy controls. So overall, once again, you can see there's some support for chemotherapy having a negative impact on cognitive function, and some evidence that, in the studies we looked at before, that it does not. Okay, so what do we make of all of this? What's the take-home message? For me, it's whether or not patients' reported cognitive difficulties are clinically relevant, whether or not they show up on objective tests of cognitive function or not, they are personally meaningful. The person knows that they are not functioning in the same way as they had before, and it can be very, very distressing. So this slide is actually a poster by a Professor Emeritus, Irving Sarnoff from NYU, and he was kind enough to let me use it. If you don't remember, forget about it. And I just kind of love that statement. It's not so easy. Okay, so on slide 21, I'm asking the critical question, is Chemo Brain a misnomer? Okay, and it's yes, no, it depends, or all of the above. On the teleconference, I don't have animation, so you can already see the answer. It's all of the above. It's rather a complex issue. Okay, and we're moving on to slide 20, I can't tell if it's 25. Okay. A subset of patients and survivors probably do have what we would consider true chemo brain, cognitive impairment that is a direct result of treatment. But we have to consider that there are other explanations for many patients' cognitive difficulties. We can't rule out pretreatment disease factors, inflammatory cytokines, and we can't rule out anemia. They all contribute. Discounting the effects of stress and depression just doesn't make sense because there is so much research that shows there are measurable brain changes with distress and depression as well. So if you're experiencing or a loved one is experiencing depression, it's important that they get assessed and treated. Okay, so I want to move on to the fun part now, which is Brain 101. And if you look at slide 27, there's a picture of a brain, 3 pounds, 100 billion neurons, and it makes magic. You have what is called lifelong neuroplasticity. Your brain can grow new neurons and make new connections throughout your entire life. So before we talk about what you can do to protect and improve cognitive function, I want to actually talk a little bit about what your brain is capable of. Recent advances in neuroscience have demonstrated how remarkably plastic the plasticity of the adult brain in response to new learning is. You're able to grow throughout your lifetime. So going on to the next slide, I want you to think about your brain as if it is an orchestra performing a symphony. And this is what I mean when I say that it's a totally unscientific primer on brain function, because we're going to be talking about music. The brain is incredibly complex. I want you to think about the elements of a symphony orchestra. The conductor is executive function. That's command central for your brain. Think of the musicians as the neurotransmitters, the chemicals that perform cognitive processes. Think of the instruments as the cells and structures of your brain. And the sheet music, because everyone has to follow sheet music, is a sensory input, okay? You don't function in a vacuum. You're taking in sensory input from your surroundings all the time. Orchestras play beautiful music, and we expect them to do that. But if you think about what it takes for an orchestra to play that music, there's really a lot that goes into it. Everything has to work together just right for the music to come out, and that is true of your brain as well. Everything has to work in concert for it to function well. So looking at slide 29, I want you to think as the conductor as your brain's executive function. This is located, executive function is located in your brain's prefrontal cortex. If you look at the little picture of the brain there, that rosy red area at the front of the brain is where executive function is located. It's responsible for complex thought, goal-directed behavior, and decisions. It observes, directs, and coordinates all of your brain's activities. So when you think about an orchestra performance, the musicians aren't always performing. They get breaks, different sections play. But the conductor is working every single moment. He is always center stage in performing. And the same is true of executive function. It's always on and always active. And that's why studies that we looked at where they show that there might be compromise of executive function are very important because it affects everything involved with cognition. So I want you to think of the instruments as the cells in your brain and the musicians as neurochemicals. Your instruments need to be structurally sound, undamaged, and in tune, but they cannot play on their own. The musician is what makes it all happen, these neurochemicals. They fire between cells, making connections so that you can learn. So what do you expect from a good musician? What do you expect from a great musician? Well, great musicians and great brains have something in common. What makes a musician great? Practice and versatility. Great musicians know lots of music. They play several instruments, not just one, and they're always trying to improve and grow. They want to grow as a musician so that violin can have a bigger, more beautiful sound. We happen to know that you can grow the instruments and the musicians in your brain and make it play better. That is what neuroplasticity is about. So now let's talk about what you can do to make that happen. That's the final section of the talk. What can you do to help maintain your optimal brain health? And we'll move on now to slide 33. Well, the first and probably the most important thing that you can do is to exercise your brain. It really is a use it or lose it deal. Your brain is an intellectual. It likes complexity and it likes challenge. So you need to solve problems, learn new things, learn new complex tasks, and practice, practice, practice. Your brain will respond to challenge by stretching and growing to meet that challenge. It might struggle at first, but with practice, it will master a new skill, it will get faster, and it will become more efficient. If you think about how difficult it was for you to learn to drive, putting together all those separate things that you had to do, looking in the rearview mirror, looking in the side mirror, keeping your eyes on the road at the same time and steering, it was difficult. But it's not difficult now. You just do it effortlessly. And your brain can learn many things in the same way. The things you already do, however, won't help your brain grow. If you are an expert at crossword puzzles, just doing more crossword puzzles isn't going to help your brain grow. It's going to maintain it. But you need to try new things. It's just like strength training for your muscles. You need to keep increasing those weights to keep the muscles growing. And so learning a new game, taking up chess, learning ballroom dancing, taking up an instrument, trying to learn a new language, all of these things will strengthen your brain. Okay. I happen to be a big fan of cognitive training programs. I know that some people are not, but I believe that the science behind them is very, very good. They provide personalized practice in critical cognitive tasks that improve fluency and improve speed. The research on the prototypes for these programs showed improvement with older adults, and it's very compelling. I think they're new now, but I think that they're worth trying. You can approach this in a couple of ways. You can find a professional who provides cognitive remediation training. That would be supervised remediation by a neuropsychologist. It's quite expensive, but if you're experiencing significant cognitive loss, that might be the way to go. But the other thing you can do is try one of the many online training programs that are available. I know of CogniFit Personal Coach, Posit Science Brain HQ, and Lumosity. These are not regular commercial programs. They were designed by neuroscientists. There is solid research behind them, and they can help. One of the most important things you can do, and we're moving on now to slide 35, is exercise your body. We know that exercise is one of the primary things that prevents people from having cognitive loss. It reduces fatigue, and we've seen that fatigue contributes to poorer cognitive performance. It increases oxygen to your brain. Trust me, your hippocampus really wants oxygen. It increases neurochemicals that support cognitive health. So specifically, even short periods of exercise will increase a substance called brain-derived neurotrophic factor, and that plays a major role in neuroplasticity, in brain growth and adaptability. Exercise improves your mood and reduces stress, and we've already seen that mood and stress can affect your cognition. And most important, studies show that exercise reduces the risk of dementia. So there's lots of good reasons to exercise. And so what can you do that's going to be fit into your schedule and not be too hard on your body? You can walk. Please walk. 30 minutes a day, 3 times a week, and more is better. There was a leading neuroscientist who recommends 1 hour a day for your brain, not for your body. And one professor went so far as to install a treadmill fit with a book cradle that goes 1 mile an hour to keep moving while he works. He walks on the treadmill rather than sitting. Evidence shows that walkers are 25 to 30% less likely to develop vascular dementia. So there's a lot of good reasons why you should walk, why that should be your form of exercise. Okay, so what are the things are involved in maintaining good brain health? Socializing. It turns out that your brain likes company. Social support is associated with better cognitive function in the elderly. It protects against cognitive impairment following stroke, and it also reduces the risk of dementia. In experiments, rats who were caged with other rats do better than rats living alone. The cortex of their brains are thicker, and they're faster at maze learning. And when you're considering social support, apparently, even if there is conflict, social support is beneficial. So if you fight with your sister at Thanksgiving or Easter, it's still better than being alone. Fighting with your friends and relatives is better than being isolated. Even poor social support has a positive cognitive effect. So another thing that you can do is to eat healthy. You have to understand that your brain needs fuel like every other organ in your body. Your neurotransmitters need nutritional support. I'm not a dietitian, so I'm not going to dwell on this, But research repeatedly shows that natural sources of the nutrients I list on this slide can benefit cognition. But natural sources are better than supplements. So try to get your nutrients from real food. B6 is essential for your memory. Choline is essential for learning and plasticity. You need omega-3 fatty acids. You need antioxidants. And calcium is not just for bone health. Your brain actually functions on calcium. It supports nerve conduction. Okay, so moving on to slide 39 here. Research with meditation has shown consistently that it reduces stress, it improves sleep. There's some evidence that it increases cortical thickness, the thickness of the cortex, the outer layer of your brain. And there's some evidence that it even improves immune function. These are all good things for everyone, but they're especially important for patients who are dealing with cancer and especially important for cognitive function. And finally, if you're experiencing serious cognitive problems, there is the possibility of medication. Modafinil has been shown to improve memory and improve verbal working memory. However, it does not improve attention, and attention seems to be one of the major deficits that cancer patients have. They often don't remember information because they don't attend to it well in the first place. They seem to be distracted, and if you don't process something, you're not able to recall it. Modafinil was originally developed for narcolepsy. It's considered a cognitive enhancer, somewhat popular sort of black market in college campuses. But overall, quite honestly, the effects are very small, and it's unclear whether the effects are even greater than caffeine. So it's not nearly as effective as exercise, and if that's the case, why would you take a drug? So I'm just a proponent of healthy living as opposed to medication, but it's certainly something that you can consider if you're having serious problems, and you should go see a neuropsychologist and discuss your options. Medication for depression, if you are depressed, will have positive effects as well. It increases brain-derived neurotrophic factor, which we discussed before. It can improve cognition. However, it's contraindicated in some patients with some treatment, so you want to make sure that you talk to your physician about that possibility. So I want to sort of end with what I think patients experiencing so-called chemo brain need to do. You need to ask your healthcare providers to help you out. You want them to provide screening for distress, for depression, and fatigue, and then they should provide support for your psychosocial needs. They either provide support or refer you for psychosocial support, for education on symptom management, to stress reduction programs, and if necessary, for cognitive testing. I know from my work that there are many people who just feel better after they've been formally tested for cognitive processing, for their cognitive function. Often seeing the results and finding that they're in normal range, even if you're having difficulties, but that compared to the rest of the population, you're normal, makes people feel much, much better and much more comfortable with the symptoms that they're experiencing. Early intervention targeting symptoms may be able to improve cognitive function, so I recommend early screening. So that's pretty much my talk. I think I wrapped it up just about on time, and I'll open it up for questions now.
So, Joyce, while the questions are accumulating, I just want to thank you because I found this incredibly interesting, and I'm sure that there's going to be a lot of people dialing in. So, Terry, would you please tell people, if they don't know already, if they have a question, how they can dial in and ask that?
Certainly. At this time, if you would like to ask a question, please press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster.
So I'd just like to remind everyone that if you have a question you would like to ask Pamela, please remember to keep it general in nature and specific to myeloma so it will benefit all listeners on this teleconference. And also, if we can ask you to please limit your questions to one, so no two-part questions tonight, please. Thank you.
Our first question comes from the line of Jack Aiello.
Hi, I appreciated the presentation as well. You reminded me that I continue to appreciate my son who conducts orchestras. And just in case it doesn't come up, you might get questions in your slides that I think your slides were either jumbled or missing information between slides 15 and 24. So the question I have is, what are the names of these cognitive tests, and why aren't they incorporated as part of quality of life issues in clinical trials? When you show an example of 2 Revlimid or lenalidomide patients who experienced this, that doesn't give one a good sense of whether that's 1 in 10,000 or 1 in 50 and things like that.
Okay, so the lenalidomide trial, let me see if I can find that slide. You know the number offhand? I'm scrolling.
It was around 20-ish, but more importantly, what are the names of the cognitive tests, and do these tests get incorporated in clinical trials?
They do. They're not very prevalent right now, but they have been increasing. And more clinical trials are starting to include cognitive batteries. One of the difficulties is that they take a long time, and they're quite expensive, and they require, people who have specialized training to administer them. But more and more they are being included in cognitive trials. I think there's not as much in multiple myeloma, but in breast cancer and in prostate cancer, they have been used. And there's was also a trial with, I'm trying to think, ovarian cancer that was funded by NCI. And there was a recent trial actually with people who had, allogenic stem cell transplant, and they incorporated these tests. So I'll give you the names. It's usually referred to as a cognitive test battery, but it includes things like trail making, digit symbol substitution tests, test of verbal memory, test of executive function, which is also often measured by word association tests, and they also include tests of reaction time and processing speed. So there's a number of them, and they're usually put together in a complete battery that takes anywhere from an hour to 2 hours to go through. But as I said, more and more they are being incorporated. One of the difficulties is that it's hard to get funding and to find the time within a cancer center to administer these in a routine way. People have been fighting for this for years, and we're getting better, but we're not quite there yet.
Thank you.
You're welcome.
Your next question comes from the line of Joyce Scholes.
Yes, this is Joyce.
Hi.
My question is if there's any things that we could practice as far as the really short-term memory seems to be an issue with me. For example, my husband will tell me something to pick up on my way to town, and in that brief little distance of going 20 miles over there, I'll forget that. And is there something that I could practice or whatever? I'm assuming like the luminosity things that you mentioned, that they would be helpful?
Okay, so lumosity, training games can help you with certain cognitive skills. I'm not sure that they do improve working memory, but the easiest way, quite honestly, is to keep lists then. Usually I'm not an advocate of that because I think you can do better to improve your cognitive function over time. But if you just want to avoid that problem, you write it down and you put it in a prominent place and you carry it with you.
Yeah, I do that and then I forget the list.
No, I understand that. We did research with women who had breast cancer, and they would say things like, I went to the bank and I forgot the check, so I went home to get the check, and then I discovered it was sitting next to me in the car all the time. So you're not alone, but that happens to everyone. So I think you just need to compensate.
Okay. All right. Thank you.
You're welcome.
Your next question comes from the line of Barbara Serkington.
That's good enough. I had two things that this very. Can you hear me?
Yes, I can hear you.
Okay. This gave me information that I didn't have before, so I really appreciate it, and I think my husband does too. The two things that I didn't hear mentioned at all were hydration. That was mentioned. And laughter.
Oh, well, I think I did not mention laughter specifically. However, I think that you can include laughter under social support. If you have a partner that you can laugh with, that's really good medicine. So I certainly encourage that. And I know a lot of support groups actually have sort of comedy sessions and things like that. So that's good. And the other one you said was hydration?
Yeah. Staying hydrated, drinking the fluids, does that have any impact on cognitive function in the brain?
Well, it's an interesting question, and I don't have an answer for you because I haven't looked at it specifically. I don't actually know. I do recall a neuroscientist saying to me at a conference that there was an unexpected result on a brain scan because a person was dehydrated. It looked like volume loss, but in fact they were dehydrated, and when they rehydrated, it disappeared. So hydration is in general good for your body and all parts of your body, but I don't know if it has specific effects on cognitive function. I'm sorry, I can't give you a better answer than that.
Well, thank you. That's okay.
Your next question comes from the line of Kimberly Jones.
Hi, yes, this is Kim. First, I just want to, I believe it was a woman named Joyce who talked about the short-term memory loss. Something what someone told me to do, because my problem is I will even forget if I took my PRN medication. I'll remember I had to take it, but I don't remember if I did, or if I plugged the iron, etc. So what a friend told me to do is to make a big deal about it, to say, actually verbalize out loud, hey, I just took my pill, I'm a genius. And for some reason that helps you remember it, if you actually verbalize what you did.
And that's actually supported by science. It's called elaborative encoding. The more you add things to remember to what you want to remember, the more you add sort of adjectives and other actions, the more retrieval paths you have, the better way you have to get back to that information. So part of it is elaborative encoding. The other part of it is really paying attention. If you might remember, I mentioned that attention is a problem. If you don't attend to something, if you do it sort of matter of fact, it's going to slip right out of your mind. But if you do what your friend said and make a big deal of it, you're consciously aware that you are doing this action, and then you're more likely to remember it. So she gave you very good advice.
Oh, that's good to know. People might look at you like you're odd, but it works. So, but my question was, and I'm sorry, my computer froze or something, but on slide 8, you talked about the change with the hippocampus part.
Right, and your computer froze?
My computer froze, or they put new internet in, so something went wrong, but I missed it. Could you give me just a little spark note on what you said?
I think I mentioned the hippocampus several times, but I'm trying to remember. Was it on the slide where I had the picture of the hippocampus in the brain?
Yeah, and I'm just curious what the actual change is.
Well, so the actual change is loss of cells and loss of volume. Okay, stress actually kills brain cells. That's what we know. And so that's really the gist of it. But your hippocampus is the area that's responsible for long-term memory.
Oh, I see. Okay, so when you're stressed, your depression, whatever, you're actually losing.
Yes, you're losing brain cells.
Some parts of that.
Yeah,
so
it's not a good thing. Stress is very bad for you.
Yeah. Okay. Well, I know I was long, so I'll let you get to the next person. But thank you. This has been very interesting.
Okay. Thank you.
Thank you.
Your next question comes from the line of Dr. Harold Hammer.
Oh, hi. Your presentation makes a wonderful description of the multifactorial nature of question Chemo Brain. Would you or has anyone made a guesstimate of what proportion of the damage is done by, in myeloma patients, their drugs? Is it 25%? Is it 50%? And has anyone done any work on what happens when combinations of drugs are used? Because when I was on 3 drugs at one time, I was very certain that the Chemo Brain, question Chemo Brain I had, was much worse than when on one drug.
Okay, so having more drugs increases your risk of having Chemo Brain. That's clear. There are some older studies that were done actually with breast cancer patients, but the higher dose of chemotherapy and the more regimens were associated with greater cognitive problems. So we know that. There's not a lot of work that's published yet. I don't know what's going on, behind the scenes in multiple myeloma and cognitive function. It's just starting to emerge. But people who are working with animal models are using combinations of drugs to see how they affect animal cognition with the goal of helping humans who are experiencing Chemo Brain. So the research, as I said, is still in its relatively early stages. I think at most we could say the earliest studies were 20 years ago, and that's young for this kind of research. So to answer your question about what proportion of cognitive loss is attributable to each of the factors, I haven't seen any research on that. It would be interesting, but right now we really don't know enough, I think, to be conducting those kind of analyses.
Thank you.
Thank you. I hope that answers your question.
Partially, thank you. I mean, if they don't have all the answers, then it does.
Yeah, but your perception that having multiple drugs made it worse for you is probably correct.
Right. Thank you.
You're welcome.
Your next question comes from the line of Jamie Murphy.
Hi. Can you hear me?
Hi, I can.
Hi. Thanks for the program. I was just wondering if you could explain a little bit more what inflammatory cytokines is.
Cytokines. So let's see. I don't have notes on that in front of me. Let's see if I can remember. There are actually these proteins in your body that cause inflammation. And when a person has cancer, it actually releases these proteins into the bloodstream. And they have an effect on the whole body. Sometimes it's called illness behavior. But they can penetrate the blood-brain barrier and cause cognitive problems. So that's kind of the best description I can give you now. I actually have something written on it, but I, off the top of my head, cannot explain it any better now because I'm not a physician and I'm not a biologist.
Okay, thank you very much.
You're welcome.
Your next question comes from the line of Joan Mark.
Hi. I know that you showed on the slide, you mentioned alkylating chemo drugs as possibly causing Chemo Brain. And you had one study on melphalan. I'm wondering if you have if you've seen any studies of a cyclophosphamide or cytoxin, if you know how if that can cross the blood-brain barrier and whether that has actual neurobiological effects?
So I can't answer the question about whether they cross the blood-brain barrier off the top of my head, but I have seen studies, and those studies were for other cancers, which is why they were not included in this presentation, because I tried to sort of keep it to time and focus on multiple myeloma and blood cancers. But there are studies of cyclophosphamide that show that it has an impact on cognitive function.
Right, and is there anything that, and these were studies that actually had the gold standard test as opposed to the one that you had for melphalan?
Yes.
Right, okay, and does it show the dosages? Do you have any memory of that? That's hard. But.
Not for particular drugs. I don't have memory of that.
Right, sure. Okay, thanks. I enjoyed it very much.
Okay, thank you.
So I think we are at this point going to take one more question, and then we will wrap it up. Terry, do we have one more person?
We do have a question from the line of Glenda Alexandra.
Hello?
Hello.
Hi. Thank you so much for your informative presentation. Can you state some important specific side effects, cognitive and other side effects that are correlated to taking high dosage of melphalan prior to a stem cell transplant?
No, I cannot. The only thing I know about that is from the studies that I reviewed for this particular presentation. But as I said, I'm not a physician. I don't study chemotherapy drugs directly, so I don't know anything more than the studies that I've reviewed. I wish I could help you, but I can't.
Okay, well, I'll find my answer somewhere else, but thank you so much for your presentation. It was very informative. Thank you.
Okay, thank you.
So thanks, everyone, and I want to take a moment to remind all of you that there is the International Myeloma Foundation hotline, and that number is 1-800-452-2873, and they are on Pacific Standard Time, and they are available to talk with you between the hours of 9 a.m. and 4 p.m. And there's also a program that we have called Ask Dr. Dury. And you can go to the IMF website at myeloma.org, and you could submit a question to ask Dr. Dury, and he may answer it online. So I hope those of you that go online have been checking out that series. Again, it's called Ask Dr. Dury. And I would like to thank Pamela, because although she's not a myeloma specifically trained person, she really did a lot of research and she worked very hard, and I appreciate all the information about Chemo Brain and how we can not only understand it a little bit, but more importantly, how we can live with it and exercise our body as well as our brain. Those are the things that I understood and are my takeaway points. Nutrition is important with whole foods and exercising, walking in particular, and then really trying to focus and like Pamela had said, to attend to what you're doing. So if it's saying, oh, I'm putting my keys on the hook now, and maybe that's kind of enforcing something to your brain to help you remember later that, oh, yes, I did put those keys on the hook. So I really thank Pamela for what she brought to all of us tonight. And I'd also like to remind everyone that March is Myeloma Awareness Month. And to help raise awareness, the IMF in 2009 declared March as Myeloma Awareness Month, and we've been working diligent to increase awareness. Last year, over 60 cities in 4 states did the same thing. And this year, we're pleased to see how many other organizations are following in our footsteps and recognizing March as Myeloma Awareness Month. And the IMF is proud to have brought people together to spread the word and achieve this important goal. And last but not least, I really just want to remind you that we've got lots of other great programs happening. We have a patient and family seminar coming up in Atlanta, Georgia on May 16 and May 17. It's a 2-day seminar. We have another one in August on the 22nd and 23rd in Los Angeles. And we round out the year in Short Hills, New Jersey on October 10th and 11th. And for those of you that live in the Virginia Beach area, we have a regional community workshop happening on Saturday, August 26th. So I'd like to say thank you again to our speakers, and also thank you to our sponsors, Celgene Pharmaceutical and Millennium. And most importantly, thanks to all of our participants on this call. I hope you have a wonderful evening. Thank you very much.